This year is a very important year for all of us who are concerned about non-communicable diseases and their future. In fact, it's probably the very biggest year, and this isn't an exaggeration, it's probably the biggest year in the politics of NCDs ever. I say that because in September at the United Nations General Assembly, there will be a high-level meeting to corral 194 member states into increasing and concentrating their action to address 4 major non-communicable diseases across heart disease and stroke, diabetes, respiratory disease, and various cancers. This is the biggest political opportunity we've had to prioritize what is an epidemic of disease that's sweeping low and middle income countries, still largely an unrecognized epidemic. In preparation for that meeting, the World Health Organization established a commission to look at actions on non-communicable diseases, chaired by several heads of state. It is already in draft form, will be published on the 1st of June. And the reason for its rapid publication is so that it can influence the decision-making that will take place in September this year. Today, in Copenhagen, there is a conference that WHO is hosting that is attempting to generate new money for investment in non-communicable diseases in these low and middle income countries. We have the Global Fund to fight AIDS, TB, and malaria. We have no global fund to fight non-communicable diseases, which is one of the greatest disparities in world health today. And to address that disparity, there's a 3-day meeting taking place now, which will attempt to find new sources of money. For us at The Lancet, we're trying to make 2018 a special year too. We published last week a task force on health financing in preparation for the Copenhagen meeting. We're working with Imperial College and others to devise an accountability mechanism to track progress on non-communicable diseases. And we have various commissions on nutrition, diabetes, and obesity that will be published over the course of the coming 6 to 12 months. This conference is part of what we see as a very important collaboration. And the reason for that is partly to do with its origins, the idea that we're uniting 2 great continents across Europe and Sub-Saharan Africa in a joint venture to address this global epidemic. But as the conference has evolved, it truly is an opportunity to have a global conversation about the progress we're making and the future challenges we have to address if we're going to really focus on non-communicable diseases as a threat. What's excellent about this meeting is it brings together both fundamental basic sciences of heart disease, diabetes, stroke, and so on, as well as the more clinical and public health sciences. And in the 2 addresses you're about to hear, that ideal, I think, is very nicely realized. So let me start by introducing our first Lancet lecturer. Calum MacRae has got four affiliations that I need to tell you about. He is Vice Chair of Translational Innovation in the Department of Medicine at the Brigham. He's an Associate Professor of Medicine at Harvard Medical School. He's a Principal Faculty Member of the Harvard Stem Cell Institute, and he's also an Associate Member of the Broad Institute of Harvard and MIT. Amid all of those affiliations, he has time to work on the human genetics of cardiac and vascular disease, cardiovascular developmental biology, and drug discovery. He's got a long interest in the link between genomics and large-scale data sets and clinical practice, and a whole bunch of other stuff that I could go on and on and on about. But I'm not going to. I'm going to let him introduce his topic this evening, and all I want from you is a very, very warm welcome to Calum MacRae.
Well, Richard, thank you for that introduction, and thank the organizers for the invitation to give this lecture, which I'm deeply honored and privileged to be in a position to give. As you might imagine from the title, I'm going to talk about the One Brave Idea Award, but I'm neither foolish enough nor bold enough to suggest that any of my own ideas are either singular or brave. This was actually the title of the original RFA. And I'm also not going to mention, to a large extent, any of the background for this particular award. Rather, what I'm going to try and tell you about is what we've been thinking about in a very narrow space in coronary heart disease as a model for how we might transform the way in which clinical medicine is done, and importantly, thinking quite concretely about why it is that medicine has reached the status that it has reached in terms of its lack of progress along the trajectory that almost every other industry or endeavor on the planet has managed to accomplish. Why do we need any new ideas? Well, I think you've heard it already from David Lomas this evening. You've heard it from Richard, that despite the fact that the standardized mortality rates in cardiovascular disease have dropped consistently, these data started in 1979 and finished in 2013, we still unfortunately have coronary disease as the dominant killer in men and women in most of the developed world. And importantly, the prevalence has really, if anything, increased over time. In fact, in the last 12 months, the actual standardized mortality ratios from rates from coronary disease actually increased in 2 consecutive years in the US. You can see from this infographic from the BHF that even locally there are so many people that will lose their lives every day from coronary disease that we cannot afford just for this one narrow niche to even step back and rest on our laurels. But importantly, this, I believe, is actually an exemplar of every single disorder that we look after, with some notable exceptions in communicable diseases, where largely as a result of a focus on the past, we have failed to, I think, drive forward to completion many of the insights that we've had in the biological sciences over the last 4 to 5 decades. I think it's probably best illustrated here in these 2 slides. This is actually lifetime risk from Don Lloyd-Jones's work, where you can see essentially that most of the estimates of risk start at the age of 50. We have not really thought about how we can begin to even measure risk earlier than this age. Probably one of the most frightening graphs here is the one that is actually looking at diabetic risk in men and women. You can see an almost vertical rise. And that's largely, I believe, because of the fact that diabetes and coronary disease are actually the same thing. Diabetes does not actually cause coronary disease. It's actually identical. It's probably the other way around. And that, in fact, the ARIC study would confirm that on the day of diagnosis with type 2 diabetes, 100% of people who are imaged actually have coronary disease. So what diabetes really does is just presage the events that we are anticipating in coronary disease. We've had remarkable effects on the incidence of cardiovascular events, although probably not from the data that I just showed you on the underlying biology of atherosclerosis as a chronic disorder, by reducing LDL. Nevertheless, there are at least 2 classes of drug which are outliers, both the CETP inhibitors and fibrates, where LDL is lowered and yet the underlying effects on the net biology are still less than we would anticipate. There's also some recent work from St. Catherine and others at Mass General suggesting that if you have an elevated LDL, but you have the genetics of the LDL receptor mutants, you are actually at increased risk over and above that of your LDL. And in fact, perhaps the template for what I'm going to tell you about is that this is actually a network, a genetic network of mutants that affect the gene wingless in Drosophila. And it turns out the LDL receptor is an important part of that wingless network, so that this fly genetic network from 1996, the Nobel Prize was actually won shortly before that, predicts not only that coronary disease and diabetes are linked, but also that hypertension and dementia are part of the same biology. And yet none of the underlying biology of this particular signaling pathway has ever made it into the clinic. And what I'm going to argue in the next few minutes is that this is a systematic problem with almost everything that happens in medicine, that we have essentially, I believe, isolated the research and development parts of biomedicine from the clinical care. And we've done that in a way that actually, unlike any other area of endeavor in almost all of medicine, creates this gulf which almost nobody has been able to cross in a systematic manner, despite decades of trying to do this. In fact, part of the reason that it is like this, I believe, is because of some perceived conflict of interest between the commercial parts and the professional parts of this endeavor, unlike any other area of activity in human nature. Perhaps another way of looking at this is depicted here. The trajectories of modern medicine are actually the trajectories of the Middle Ages. They're the trajectories of Hippocrates, to be honest. We sit in our ivory towers or our clinics or our urgent care centers, and we wait for people to show up with symptoms, clinical disease onset. Perhaps in cardiology and now increasingly in diabetes, there is actually an effort, quite a substantial effort, to move into prevention. But this is where every other part of every other industry on the planet operates, is at the very start of the problem, at the very start of disease. And in fact, even this line is depicted in a way which suggests that we're only even beginning to think about prevention at birth, whereas obviously it antedates that by many, many, many months or even years. And in fact, looking at transgenerational transmission of risk, we probably should be looking, if we want to really impact non-communicable diseases, at the most elderly individuals in our populations. The award that we received was actually a substantial amount of money, which we've actually used to raise additional money. And I'm not going to talk to you about the mechanics of the way in which the project was put together, except to say that this is really designed to create an effort in a very narrow space in biomedicine that has parallels with a startup company in almost any other setting. And the title of the application that won the award was Redefining Disease at the Edge of Wellness. And I think that's actually the core message here, is that for almost 2,000 years, we've defined health as the absence of disease. And what we really need to be doing, particularly if we're going to be able to reinforce people's willingness and ability to maintain their health, is to actually be able to measure health in a definitive and quantitative way. And obviously, this would impact coronary disease or coronary heart disease or atherosclerosis by being able to detect that first transition from health to disease. And this was a remarkable consortium of physicists, genomicists, elementary school teachers, venture capitalists, all coming together around the fundamental question of, can we find ways to actually measure health in a rigorous and robust fashion? Perhaps another way of thinking about this, when I began to write the application, I will point out it was only 250 words, which is, as you're probably already gathering, about the limit of my capabilities, was to actually conceive of it in terms of the three funders. And this was Verily Life Sciences, part of Google, AstraZeneca, a pharmaceutical company very similar to many others, and the American Heart Association. I had to think quite a lot about where to place each of these images, because it's not entirely clear. Again, partly because of that bifurcation that has taken place in medicine for centuries, where exactly the investigation, the delivery of care, the collection of information all sits. But suffice it to say, the goal of our program is to try and, at least in one narrow space, begin to form the foundation of this learning health system. And I'll talk briefly at the end about this output phase, the delivery of the care that we know already we should be delivering, and focus in the first instance on data collection and analytics, which I believe are obviously some of the rate-limiting steps, although not the only rate-limiting steps in the formation of this learning health system. What's actually missing from the portfolio of tools that we have in modern biomedical science that would allow us to actually execute on this promise, which I have to tell you was present the day that I graduated from Edinburgh University in medicine. Personalized medicine, precision medicine, molecular medicine, all of these are names that we've given something, and we change the names every 7 years or so, partly because we've failed to deliver on the prior promise. And I would argue that the reason that we have failed is fundamentally a result of some of the topics in this slide. But I'm going to focus on what I think are the most important ones, and those are information content. Most of what we collect in medicine could have been collected, although perhaps a little less broadly, in the middle of the 18th century. Biology, most of which sits outside medicine and has not been translated except in as much as some pharmacological agents have made the transition. And then ideally, I'm also going to have time to talk about trajectories. Many of the other things on this slide you can see are actually quite important hurdles, but I believe these are much, much more close to being overcome than the three that I'm going to highlight, because these three actually turn out to be fundamentally a function of, I believe, the role that the medical profession has played in institutionalizing the collection of the information and the distribution of the alms from the center of the clinic. So the rate-limiting problem in almost every sphere of medicine, I'm not going to deal with this in any great detail, whether it's genetics or genomics, drug development or clinical trials or care redesign, is the information that we collect is just fundamentally flawed. We collect reams of data that are actually highly redundant and almost without exception worthless if it comes to actually thinking about how to implement large-scale analytics. It's not by accident that almost every large IT company is now pulling out of their relationships with large academic medical centers, certainly the US. Baylor and IBM recently began to unwind the relationship, largely because of the fact that almost everything that we collect is based, as I mentioned, on the 18th century. We've succeeded perfectly in digitizing that phase of medicine without actually asking ourselves, what do we need to collect in order to drive the field forward? So in genetics, we've spent a lot of time looking at large effect size alleles in Mendelian disease, now common alleles in genome-wide association studies. Yet if you add the top 100 loci for diabetes together, they actually explain less of the risk than 10 pounds of weight gain. And importantly, you can modify your weight, but you can't modify your genetics. Similarly, this picture, I believe, of the precise therapy, the stratified care that we all wish we could deliver, is something that even in cancer, where we actually have the disease in our hands, has proven evanescent and not feasible, and certainly hasn't impacted any other area of biomedicine. And I would argue that's largely because we have no way of distinguishing these types of individuals in any meaningful fashion. Partly, again, because we're relying on phenotypes that were defined either by common collection 30, 40 years ago, or by very unusual extreme pedigrees. And in fact, in the genetics field where I work, what you would anticipate, even from studying the work of Mendel, is that the majority of diseases are going to actually be in this range here. This is how genetics works. It prepares the organism for interactions with environmental variables. And of course, you know immediately when I say that we measure only two environmental variables routinely in almost all of medicine, alcohol and tobacco. And even there, we do it by semi-subjective report rather than by objective data. So for example, almost every major gene that you would anticipate being important in a species that only recently began to survive beyond its period of acute reproduction would be something that would actually be the result of the ability to deal with a measured conditioning variable. And since we don't measure any of those, it's hardly surprising we don't understand the mechanisms of most diseases. And then finally, perhaps the nail in the coffin, and this is something that I think really just demonstrates how difficult the next few years are going to be, is that where we have looked at moving intensive care unit physiology into the home in an effort to try and prevent heart failure readmission, every single one of now 6 randomized controlled trials has failed to show any effect, even on as low a bar as 30-day readmission. And in fact, perhaps the most important insight from these studies was that the only thing that really predicted risk of readmission when you already have heart failure was chatter, was communication chatter, either an increase or a decrease in the way in which you relate to the people around you. Again, suggesting that that biological set of data is perhaps more important than heart rate, physiology, thoracic impedance, or even PA pressure in determining when you come back into hospital, when you re-engage the medical profession. And so in summary, in almost every area of medicine, the phenotype is actually rate limited. We have essentially settled for cross-sectional collection of static or limited dynamic range data for centuries. They're almost all aggregates of things that we know already are disparate. I mean, it is actually amazing to me that every single cardiologist in the room can tell the coronary angiogram of a diabetic from a non-diabetic, yet I have never seen a single genetic study that ever actually looked at those differences. And again, that type of fundamental failure for the mechanisms to connect with the clinical trials or the clinical studies is remarkable. And almost everything we collect is unidimensional with no organizing metadata. So the reason that when you put a heart rate monitor and implant it in, or PA pressure monitor in somebody, that you don't really know what's going on is you're not collecting any of the organizing metadata. You don't know what that person had. You don't know what for dinner that night. You don't know what stresses they're under. You don't know what other biology is impacting those recordings. And in fact, as I mentioned, almost no conditioning variables ever recorded. Perhaps this is the quantitative result of what I was just saying, that if you add every single clinical phenotype in all of medicine, and I had the chance to do this as part of the Undiagnosed Diseases Network in the NIH, they were actually concerned about what they might be on the hook for financially. But if you add everything up, and it turns out this is the same for every species, the total number of phenotypes that we record in clinical or even preclinical disease biology is about 9,800, so about 10 to the 4. Everybody in the room differs by about 10 to the 6 of their 10 to the 9 nucleotides. So it's hardly surprising that we would be unable to deconvolute a genome when we're off probably by 5 to 7 orders of magnitude in terms of the density of information that we collect from the patients. And that's before you even get into transcription, proteomics, connections, or a lot of the physiology, which is very different depending on whether you're looking at microseconds or years or anything in between as your time scale. And then I mentioned the exposome, which, as I said a few minutes ago, we do almost nothing to actually document in any meaningful way. So I believe what we need to do is to begin to move beyond the legacy data that we've spent billions of dollars collecting. So for example, the Partners Healthcare System, I have the fortune to co-chair the research electronic health record integration part of that program. We spent $1.5 billion on an electronic health record that when you show it to anybody from any other industry says, yes, that's fantastic, that's roughly where our supply chain was in 1985. And in many instances, in fact, in almost all instances, the way that we manage disease is so firmly rooted in the 1800s that it's difficult to understand what it is that has prevented us from changing it. So for example, when we started to look, and this is a panoply of phenotypes that we began to collect in a trial of insulin resistance due to laminopathy. It was actually a dilated cardiomyopathy trial when it started, but we realized that everybody who has lamin AC disease has some form of insulin resistance. But this metabolomic profile, where branched chain amino acids are abnormal, it turns out to be a predictor of diabetes 15 years before there's any abnormality of plasma or urinary glucose. But because of the way that we have anchored the therapy around essentially the hypoglycemic side effects of some medications, we have essentially ended up missing a 15-year gap between the time when we can actually identify people who are already suffering from the metabolic disorder that will manifest eventually as diabetes, at a time when we could modify their behavior, when we could begin to change their approach to all of the lifestyle that we know for sure will actually impact their outcomes. And so we've begun to take, whether it's mapping of adipose tissue, thermography, or even machine learning of the electrocardiogram to define those features of the EKG that are truly predictive of insulin resistance, which it turns out there are several. As well as vascular bedside capillary studies using whether it's OCT of the eye or subungual single fiber confocal microscopy, bringing some of the actual biology that has existed and maybe many of you contributed to actually directly into the clinic in a way that has really not happened in a systematic fashion before. And so the overall theme of this program is to try and move beyond these existing risk factors, which, as I said, I believe are just simply a reflection of the underlying diseases rather than any bona fide risk predictor, and to move much, much earlier in the disease process to the point where behavior can actually be changed. The pretty good data that you can't really, in any systematic way, affect behavior change after puberty. So you would have thought we might have built an approach to detect risk before puberty, particularly if that were lifestyle related. and ideally begin to think about a strategy for unbiased phenotyping that is focused on the earliest changes in the disease, moving progressively earlier. And this is something I believe that everybody in the room has thought they wanted to do since they were medical students. But for some reason, the system prevents us from doing this. And so how do you begin to overcome that in a meaningful way? And I think part of doing that is to engage parts of the world around us that we have failed to engage up until now. This is a diagram from Peter Libby's outstanding, most recent, and I know this diagram goes back a long way, outstanding review of the atherosclerotic process. And I'm privileged to be able to work with Peter as we begin to think about some of the very early features of atherosclerosis. But if you look at this diagram, all of the slices to the right of the first three are really where almost all of the insights in the last 3 decades have occurred. But in reality, we've known since the Vietnam War that there are abnormalities in these first 3 slices. And the difficulty is that these first 3 slices actually represent the first 20 to 40 years of life. So they are vastly underrepresented in the studies that we have undertaken to date. And so the goal of this program, it's illustrated here, is to take generic pre-coronary disease, to identify using a host of orthogonal technologies. I'll show you some of those that we're systematically trying to try and identify different underlying forms of coronary disease. To then use that to develop new ways, this deep phenotyping, new ways to identify at scale different forms of coronary disease so that that could be then implemented across therapy, across clinical trials, across fundamental biological studies, and ideally doing this in a way that ultimately many of these technologies would be scalable and could be used in the general population and move us towards even the more helpful introduction of therapies that we know already are effective. The strategy that we've used is one that we'd actually already begun to look at in heart failure about 4 years before this award. We recognized actually almost 7 years ago that you could begin to parse left ventricular hypertrophy or left ventricular dysfunction based on a series of other electrical phenotypes. So for example, it's possible to pick out senile amyloid or familial left ventricular failure based on simple measures that you can actually add to almost any clinic visit. And we've begun to do this in a systematic way at the clinics at Brigham and Women's Hospital. An insight that we began to extend even further when we looked at the biology of arrhythmogenic right ventricular dysplasia. So it turns out that all of the cell biological abnormalities in ARVC are present in a buccal smear. And you could even actually use that buccal smear to show the response to therapy. This is published work. And so what we thought was if that will work in heart failure or even just in stratifying echocardiographic phenotypes, maybe we can take the same general approach to trying to identify the earliest features of coronary disease. And many of these are things that you would already recognize from clinical practice. So you probably saw the paper in the literature a couple of weeks ago showing that essential automated analysis using machine learning of retinal images, very straightforward retinal images, is able to perfectly predict diabetics from non-diabetics, not a surprise. But importantly, in people who are not diabetic, is also able to identify those who are at dramatically increased risk of coronary disease. And this risk factor turns out to be about as powerful as an LDL. We've waited probably too long to actually try and understand why it is that macrophages accumulate lipid in many forms of underlying atherosclerosis. And so what we've begun to do is to actually look at technologies that allow us to, using topical sensors, identify the membrane biology of steatosis, of macrophage handling of lipids, using wearable devices that are actually already in development. John Deanfield is in the audience, and I've said this before. I think John's work from a couple of decades ago is really pioneering in this phase, that he showed that not only the relatives of familial hypercholesterolemia patients, but also those of premature coronary disease who do not have that underlying genetic defect have vasomotor abnormalities. And so working with both Microsoft and Google, both of whom have made tonometers that are completely portable and totally wearable, we've begun to study the dynamics of vasomotion in teenagers, both those who are at risk from FH, those who are at risk from premature coronary disease and beyond. And then finally, the other thing, and something that I should mention, is that I think there are only two unifying types of influence. There are only two perturbations that we can bring to the table in any biological system that allow us to understand something at a molecular level and at a population level. And those are small molecules and biophysical challenges. And so, of course, perhaps the most important small molecule challenges that we all recognize are drugs. And yet we throw away, in every one of our patients, every day, information on the response to drugs, over time or even acutely. So what we've begun to do is actually look at the young relatives of individuals using microdoses of drugs in an effort to try and identify, are there individuals whose LDL receptor availability or whose lipid handling is perturbed when they're 3 or 4 months old, 3 or 5 years old, in a way that we can actually build a barcode not intended to supplant traditional clinical encounters, but rather to enrich and develop those encounters. We've also, in parallel, as you might imagine, working with people like Google, begun to collect environmental information, whether it ranges from the Scottish breakfast, black pudding isolated here, through a whole host of geospatial data, or even, as I mentioned, to connectivity with your neighbors, with your friends, with your family, or with your pharmacist. It's potentially possible that the single biggest variable in the determination of drugs is actually how we prescribe them and how the patients are able to get the access to those drugs. And what we've begun to do is try to build out an ecosystem that allows us to integrate this information with the clinical data that we're collecting. What we've done is to put this into a next generation phenotype program, as I mentioned, that we're actually implementing in the clinic. There are a whole host of things that you might imagine adding to this. The most important thing we believe that we can do is to try and identify how it is we take biology and move it into the clinic in a way that actually predicts success at a scalable level, and ideally information content rather than just the ability to make it a wearable, which is, I think, what has dominated the consumer market up until now. An important piece of this is actually the small molecule or the biophysical component. In terms of small molecules, I alluded to drugs, and we're looking also at nutrition in a systematic way. Are there defined meals that will allow us to define the responses to particular chemical constituents? I think you probably saw the work from Leif Erikson's group showing that there are 5 distinct patterns of glucose absorption after a meal. That actually has been known probably for about 10 years, but we haven't really been able to move that into the clinic, partly because the sensors are not available to do this. And then finally, the other area that I mentioned is biophysical challenges. And there are many parts of our lives where there are multiple biophysical sensors, which we don't use. And we've begun to partner with automotive companies, with car companies, many of which have the ability to integrate their sensors with other detectors in the car. And the goal would be to efficiently scale this to the point where these technologies can be ambient. Ideally, what you'd like to do is to take this sort of trip where you begin to think about the biology that we already know, cellular, molecular, or physiologic, validated in existing cohorts at relatively low cost, move it towards actually even just identifying those at risk, but ultimately towards new biology, and with it to democratize not only the phenotyping, but also the ability of individual patients to participate in clinical trials. There are a whole host of orthogonal approaches that we're using. In the last few months, we've shown very clear developmental biology abnormalities in coronary heart disease. Actually, one of the things that amazed me most, I've worked, as you can probably tell, in heart muscle disease for the last 25 years. And moving back into vascular disease with Peter's guidance, one of the things that was most striking to me was there's not a single study out of 22,000 mouse studies of atherosclerosis. There's not a single one on developmental biology. We've actually begun to have children in elementary school help us define what wellness really is in their terms, using microbiome assessments, transitions of social behavior, a whole host of other things that we believe are important. The nutritional assays that we're using have the ability to map way beyond a food frequency questionnaire and expand dramatically the intensity of chemical information from the 150 or so compounds that are in the traditional dietary assessment to over 50,000 compounds, many of which we know already have biological activity. We've also begun to move, this is actually the map of individual functional assessments of every residue in a gene that we know already causes coronary disease, ApoB, And what we've done is begin to work with Fritz Roth's group to actually build out quantitative assessments for each variant. So instead of variants of unknown significance or mutations, we're actually making quantitative probabilistic inferences about the biology and trying to do that in the context of, as I said, a startup company where people are not stuck in one field, but are moving rapidly and efficiently between these. And the goal would be that we could begin to think about a computable, and these don't have to be sophisticated or expensive assays. In fact, the goal is to make them the exact opposite. But that define health in its most granular and dynamic form in terms of resilience and robustness, and allow us to begin to monitor individuals all the way through their lives. And I believe that these new data streams from multiple different dimensions will not only cross the individual boundaries between medical subspecialties, the limits between cardiology and nephrology and other fields, but also allow us to begin to assess response dynamics, not only at baseline, but in response to our interventions, which we never really care that much enough to actually measure the dynamics in any meaningful way. And in fact, I believe, and we'll actually show you a little bit of data in the last two slides, that most of the variation that we measure in human disease at the moment is actually variation in the way in which we deliver care. That most care is delivered so non-uniformly that it's almost impossible to make any inferences in somebody who's already on therapy, even in a randomized controlled clinical trial. The other options for this obviously are that it allows us to begin to do what every other industry in the world has done, and that's to optimize things in real time and to create networks that actually are all working together seamlessly to deliver the right care. I mentioned implementation, this output limb of the system. And in fact, one of the scariest things about this is that even in the current state, so this is those individuals in a fully insured population in North America who have all of their risk factors at goal, these are diabetics, fewer than 20% in total in a very large and active clinical provider in North America. The scariest thing is that these are actually very standard data for most of the developed world, that we have failed to systematically implement the things that we know work. Much of this, I believe, is because of us, the physicians, the providers. What we do is we add cost, we add variation, we add arcane workflow practices. We add things that make us feel better about ourselves rather than things that make the patients feel better or live longer. We also add timing constraints and scaling constraints that in no other part of our lives have we held on to the arcane practices of guilds from the Middle Ages. We do supply, thankfully, a little bit of pattern recognition, a bit of biologic insight, but as I mentioned, we don't really strive very hard to move that into the clinic. We definitely add some pharmacological insight, and I believe we add the human connection, although I'm not completely convinced that that has to be the human connection with somebody who has 30 years experience. Perhaps the thing that's most important that we still have to be able to add is investigative function. And that's something I think that most of medicine realizes has happened over the last 20 years. We've been systematically deprofessionalized. And the way we've done that is by holding on to the algorithms that in every other industry have been given away to non-professional intervention. And that's partly why we've ended up so unhappy, so distracted, and so, I believe, burnt out, is because we're still doing things that should long ago have been left alone by the medical profession because we know enough information to be able to implement them without a professional. The sad thing is the digital adoption, even in San Francisco or in Massachusetts, is very low in actual patients. And so what we've done is build a whole slew of navigator-driven, these are basically high school graduates or college graduates, can deliver care in a systematic way with algorithms that we've written using standard guidelines. And implemented in a way where people can, within 2 weeks of starting the program, manage lipids, manage blood pressure, manage heart failure, manage diabetes, and impressively have results that actually, even in a fully insured population in the US, have dramatic effects of 40% LDL reduction, 20 millimeters of systolic blood pressure, 12 millimeters of diastolic blood pressure reduction. And these are patients who had actually been treated in the system for 2 years after their index MI or their index stroke. Importantly, the provider satisfaction with the human connection is actually probably not as unique as we would like to believe. That, in fact, in almost 77% of the patients thought they got a better human connection from the navigators than they did from a provider, largely because they could actually get through to that human, where often they can't get through to the provider. So the hope would be that by building platforms that improve the data return cycle, ideally to the level where it's actually rigorous enough for regulatory approval, and improve the uniformity of the implementation cycle, that we could actually begin for the first time to integrate care, innovation, and discovery in a single system. And I believe this will actually allow us to begin to not only deliver the things we know work, but actually learn in a rapid and efficient fashion new insights that we don't need to have large external funding to gain, that we can actually test things in the system. For example, Google will test multiple things in almost every web page, and they usually say that within 15 minutes they know what works worldwide. Why is it it's taken us 25 years to actually even understand whether heparin is worth giving in an acute coronary syndrome? Well, it's because there's no external funding. That's the type of thing that you can begin to understand within days, within minutes, if you have enough people enrolled in a system that actually is recording the responses and the outcomes. So in summary, I think information content is the rate-limiting phase of almost all of biomedicine. The need for new information actually offers a unique opportunity to redesign almost everything that we're doing. And you can see this in the world around us as care is redesigned, as care is devolved. We have to take the bull by the horns and actually begin to make sure that as a profession we're driving this so that it doesn't become something that's just consumer technology. I think there is the ability to create personal profiles or trajectories, whether you're in sub-Saharan Africa, where actually I have to tell you the vested interests resisting this type of system are much, much lower, or whether you are in the developed world. But the most important thing, I think, and this is probably the thing that we've failed to deal with, if you want to have personalized medicine, you need to be able to attribute causality at the level of the individual. And we're so far away from that it's actually frightening. To be effective, we need to create a completely new ecosystem, I believe, and that has to actually allow for real-time probabilistic logic, the way that your television, your grocery chain, your car, every other part of your life actually is much more rigorous than any medical implementation cycle. And then at the end of it, I think the most important thing to remember is that biology is the only real constant in all of this. And if we hold on to the things that we've believed for centuries make us who we are, we're actually, I think, essentially robbing our patients of what we could bring to the table, including the biology of the patient-provider interaction. This work would not be possible, obviously, with a lot of help from either our eCare and population health management teams, our Center for Clinical Data Science funded for a large amount of money to do high-scale analytics, the Partners Connected Health team, the Brigham and Women's Cardiovascular Innovation team, in particular, Ben Sirica, who's done a remarkable job building this out. And then the One Brave Idea funders, the HA, Verily, and AstraZeneca, as well as some other funders, and these individuals, including, importantly, Rob Califf, who's had a really remarkable effect in helping us think about how this could all be done in a regulatory compliant fashion. Thank you for your attention.